Okay,
Okay.
well,
Sorry, I can give the introduction now that everybody is here and recording for all our friends at home. My name is Dr. Haggerty. I am a professor, an assistant professor at Thomas Jefferson University in Philadelphia, PA. I'm also one of the coordinators and co-founders of Anato-Bee with Drs. Peterson, Mapes, and Piscira. And this is our second anatomy tutoring session. So we have some wonderful medical students here to help tutor you. As you all know, we are going to go through some practice questions from the lectures that you have watched that were put together last year. And we're going to take a look at some questions in anatomy. Did you study our website today? You're going to look at some questions in anatomy, histology, and embryology. And of course, we'll take a break at the end if you have any questions to ask our wonderful medical students. So make sure that you guys are going through the content before you come on. Make sure you have access to our Google Classroom. That's where you can find the scheduling, a lot of the content, and you can check out our badge program, which is new this year. So if we don't have any other announcements, I think we're ready for Dr. Frank to introduce our first medical student.
yes, okay. And if this is your first time, if you didn't come last week, I'm Dr. Bill Frank, and I will be serving as your humble moderator again this year. I'm an associate professor in the Department of Neurobiology and Anatomy at the Drexel University College of Medicine. I'm a colleague of Dr. Peterson. And so when I'm not teaching or in the anatomy lab, I love spending my time with my wife, Miriam, listening to her playing music, and I listen from everything from Mozart to Megadeth. Um, I live by the mantra, anatomy is like a box of chocolates. You never know what you're going to get. So with that, I will introduce our first uh, presenter this evening, who will be presenting on the anatomy of the skeletal system. Taylor Leistiko is from Missoula, Montana, and graduated from Carroll College with a bachelor's in biology and a minor in chemistry. She worked as an EMT and volunteered with a local fire department during her gap years. She is currently in her second year at the Pacific Northwest University College of Osteopathic Medicine. Her primary interest is in the field of emergency medicine. When not studying, she is out camping, hiking, fly fishing, or hanging out at the lake paddleboarding with her dog, Izzy. So, Taylor, it's all yours.
All right, thank you. I'm going to go ahead and share my screen. Okay, can everybody see it? Okay. All right, so I'm Taylor. I'm in my second year of medical school, and I'm going to be doing the skeletal anatomy today. First off, my questions are all based off of the lecture that Zachary Zook gave a couple years ago. So I just wanted to give him some credit. All right, and then here's the learning objectives with the link to the lecture if you need to review that. So we'll just go ahead and get started. Okay, so first question is a little case that I made up. So you have a 25-year-old that presents to the emergency department after crashing his motorcycle. He's complaining of right thigh pain, and his x-ray reveals a mid-shaft femur fracture. What type of bone is this, and what is the associated landmark? And then we can do a poll for this one too.
Sorry, is that pool up for everybody?
Yeah, I can see it.
Okay.
Just give you guys a minute to think. And then I had a little picture right here in case this helps with the fracture right here in the middle of this bone.
Dr. Haggerty,
Can't see the pool.
it looked like it launched and then it immediately closed. I don't think
All right, can
anybody had a
you tell me in the chat if you can see it? Can see it now. Okay. Got you. Still can't see it.
We can't.
Okay. I don't know why. Let me try to launch a new one.
Perfect.
Okay. You can see it, but you can't enter anything. Dr. Frank, I was going to work the polls tonight, but I'm a co-host, so it might be something with that. Dr. Frank, do you think you can try the polls for us? Maybe it's something from a co-host end. There we go.
Looks like it's working now.
All right. Sorry about that, guys.
Sorry.
Just give you guys like another minute or so to put your answer in.
Taylor, you just tell me when you want to close.
Oh,
We typically wait, Taylor, till about 75% or 80% of students have put in an answer.
okay. All right. We're at 76% right now, so we can go ahead and close it. Okay, so it looks like you guys were kind of tied between A and C. So I know that the epiphysis versus the diaphysis wasn't super clear maybe on this question, but the correct answer is C. Um, see if it'll click to the next slide. Oh, there it goes. Okay, yeah. So this is the femur, so it is a long bone. So good job with that. And then the diaphysis is right in the middle. The epiphyses are like at the ends of the bones. So since the fracture is right here in the middle, that's why it's letter C. And then here's a little review. So the femur is a long bone. Short bones are like more square. So you kind of want to think like your like wrist and ankle bones. Then your flat bones are just that, they're flat. So example is that the sternum. And then irregular bones are like your vertebra. And then a sesamoid bone is like your patella. They're just kind of like different in a different category. So they call them sesamoid bones. Does anybody have any questions about that specific question? Okay. And then here's some more review of some of the landmarks. So just a reminder, like tuberosities on bones are like ridges or bumps. The sulcis are like little grooves or indentations, so kind of the opposite of a tuberosity. And then foramen are little holes in the bones. And then the heads of the bones are like where the bone touches other bones, usually at like the top, but not always. And then, like I said, the diaphysis is like right in the middle in here. And then the epiphysis is on the ends. And those in general are specific to just the long bones.
Hey, Taylor, we did have a question in the chat. What would be the
Okay.
difference between a short and a sesamoid bone?
Um, so your short bones are just like little squares, kind of, and they're mostly just like your wrists and ankles. And then your sesamoid bones are just like the patella is just kind of different, if you can see it right there. It's not really squarish, and then it also like it kind of helps where ligaments are attached to the bones, and like your short bones are just kind of like when I think about the wrist and ankle, they're all lined up right next to each other, and there is like some ligaments, but your sesamoid is just it's kind of hard to describe, but it's kind of just like an irregularity, and um. I know this isn't like a super good explanation because a lot of it is just like memorizing which is which, but I would really stick to the like square thing versus just kind of like in its own category.
Yeah, and what Taylor's really describing is the view of the. Also, if you hear screaming in the background, I'm very sorry. That is my 2-year-old toddler. He is finding his voice and he is singing to his people. So, I apologize for that. I think Taylor did a terrific job talking about kind of the sizing of our bones. The short bones, yes, they are more like square-like. And then the sesamoid, she said you can find in weird places. That's because the big difference is the development. So the sesamoid bones develop in ligaments or tendons. So patella is one that does develop in everyone, right? Well, typically develops in everyone. And then the weird places are where you have and ligaments. You can get some sesamoids that grow. Sometimes we find them. If you can point to your image in the cuneiform in the foot. So in those shorter bones where all those ligaments are, or in between the metatarsals, sometimes you can have them grow there, which is they're not really supposed to be there. Whereas those short bones go through a process called endochondral ossification, and that's one of your regional objectives that we will talk a little bit later on when we get later into our learning objectives. But for now, let's just kind of concentrate on the different bones, and you can kind of put in the back of your brain there the difference between those are the development.
Another question in the chat, Dr. Haggerty and Taylor, do you see that?
Um, oh, do both sesamoid and short bones provide tendon stability, or is it just sesamoid? Um, I'm not 100% sure on this. I think it's more like when I was looking at the content review for this, the knee is like your main sesamoid bone, and in the knee, there's a lot of ligaments in that area. So you do have some ligaments around the short bones, but I just threw that in because it was just to help you remember that it's with the knee, and the knee has a bunch of tendons and ligaments as well.
Yes. So our sesamoid bone, again, sesamoids grow in tendons or ligaments, and the sesamoid bone is a special, or the patella is special in the sense that it does typically grow in what we call the quadriceps tendon, right? And it does provide a pathway for that long tendon to attach to the lower limb bone and into the muscle. I will say what gives stability is the tendon itself or a ligament. Tendons and ligaments will give stability to a joint. So that's how you should actually be thinking about this. It's not that the bone or the sesamoid is going to give stability to the tendon. It's that the tendons, the ligaments, the musculature around the joint will actually pull all those structures in to help stabilize that joint. And that's like at the shoulder or even the little joints in your fingers or at the knee where we see that patella. Um, that's how I would think about it.
Mm. The next one. Okay, so the same patient who crashed his motorcycle is also reporting of excruciating knee pain. So he points to his patella and says, "It hurts right here." So, what kind of bone is your patella? Kind of gave this one away when I was explaining the other question.
I'll go ahead and end this one, Taylor.
And you guys did a great job with this one. Everybody got that it was the sesamoid bone. So, great job. Okay, next question. So we can also do a poll for this one. And then the thoracic vertebrae are made up of how many vertebral segments? Give you guys a couple more seconds. Everybody's answering. Okay, that's probably good. All right, and it looks like both people got B, which is correct. Hope I didn't advance my slide too early, but it's B. So something to help you remember the vertebra and how many are in each one is this little like memory aid that I came up with. So if you think about like the order you eat your meals, like breakfast, lunch, and dinner, if you eat breakfast at 7, like 7 a.m., and then you eat lunch at noon, and then dinner at 5, that corresponds with the order of the vertebra. So cervical, thoracic, and lumbar. So you have 7 cervical, so that's the breakfast at 7, and then lunch at noon, so 12 thoracic, and then dinner at 5, so 5 lumbar. And then your sacrum is also 5 vertebra fused together. Okay. And then here's just a little review of the axial skeleton. So your vertebral column is part of your axial skeleton. So is your skull, which is made up of all these bones, and then as well as the thoracic cage, which is made of your sternum and then your rib cage. And then this is, I'm not sure if you guys need to know all of these parts of the bones, but I thought this was a good picture to help with that. Is there any questions on the axial skeleton? Okay, go on to the next question. All right, case 2. So, a 65-year-old female presents to the emergency department after slipping and falling in the shower. She reports of 8 out of 10 pain in her left hip, isolated to the os coxa. What 3 bones make up the os coxa, and then are they part of the axial or the appendicular skeleton?
It's a tough one.
Yeah. Answers are pretty split.
Yep. We'll end in 3, 2, 1.
All right. So yeah, you guys are pretty evenly split between all of them. It's actually gonna be B. So your os coxa is your hip bones. So it's 3 main bones all fused together. It's made of the ilium, the ischium, and the pubis, and all of those are part of the appendicular skeleton. So look at the picture. So here we go. This picture, like the green, is all the appendicular skeleton. So you can see it's like your limbs and the bony girdles. So your pectoral girdles are your clavicle and your scapula, and then your pelvic girdle is what the like os coxa is, and that's all your hip bones. Um, and then you see this one, the yellow is the ilium, and then the pubis is like kind of more in front, and it's the orange. And then your ischium is more in the back, and that's the purple. And so those 3 make up your os coxa. And then don't get confused with the sacrum, because the sacrum is part of the axial skeleton, but the like hip pelvic girdle is part of the appendicular. And then this is everything put together for you guys if you need to come back and reference the axial and appendicular. Does that make sense to everyone? Is there any questions? Let's see. Okay. We'll go on to the next one. Okay. Which of the following is not true? A, cartilage is soft, elastic, and flexible. B, cartilage is made of osteocytes. C, cartilage is found in the ears, nose, and between vertebra. Or D, cartilage is found in the cartilaginous joints on the rib cage. And the key word here is not true. Go ahead and close it. Right. Good job. Most people got that it was B, which is correct. And here's a little chart comparing bones and cartilage. And then you guys are going to get more in depth of this, I believe, when you go into the histology section. But this is just a quick little reference guide. So the bones are made of osteocytes. So if you remember, osteo means bone, then everything osteo is bone, and then chondro for cartilage. And then the bones are hard and rigid, cartilage is more flexible. And then these is just where they're located in the body. So skeletal bones, femur, humerus, skull. And then your cartilage is on your ears, tip of your nose, in between joints, in between vertebra. Okay, next question. Susie, a 19-year-old female, presents to the ER for right knee pain after falling off the side of a mountain while during a rock climbing search and rescue drill. So luckily, she was surrounded by first responders who brought her to the hospital, and miraculously, she did not fracture her leg. While explaining the X-ray imaging to the patient, she asks you, "What type of joint is my knee?" So how do you respond? Give you guys just a couple more seconds, and then we can close the poll. All right. Okay, good job. Most people got that it was D, which is correct. So we're going to be thinking about the knee joint, and your knee is a synovial joint, and the type of synovial is a hinge for the knee. So this is just a really good picture of like a summary of all the different types of joints. Um, so your fibrous ones are like, if you think about all the bones in the skull, those are all held together with fibrous joints. And then a good example of cartilaginous is where your ribs are joining together with cartilage right here. And then your synovial joints have a bunch of different types, and that's what allows your joints to do free movement. So for hinge, I like to think of like a door hinge, like opening and closing. And then another example of that is on your elbow. Ball and socket, if you kind of think about like a golf ball on a tee and then it can like move around a lot, or kind of like an ice cream cone, that one allows for like the greatest range of motion. So if you think about like your hip joint right in here, that's what allows you to do a whole bunch of motions. Like, so you can do flexion, extension, abduction, adduction, and then the internal and external rotation. And then for plane, it's just like think about like sliding or gliding. So a good example of that is down in your ankle. Um, does that all make sense to everyone? Do you have any questions? Okay. Um, and then here's just like a zoom in on the knee joint. So kind of what I was alluding to earlier. It's a little bit more complicated joint. You got like a couple of these ligaments in here, and then this is a more like summary. Is this of the synovial joint? You have like synovial fluid, some cartilage over here, the synovial membrane, and it's kind of like this space in between where the bones meet. And so actually, if you don't have this, your bones can like rub, and you can have like joint pain, and like people that have osteoarthritis might have this. So. The knee's pretty cool. Okay, next question. So, right as you were about to check on your other patients, Susie, the one from before, tells you, "Thank you so much. My knee feels so much better, but now my shoulder's really bothering me." So, Susie's very curious about her injuries and she tells you she has an anatomy exam tomorrow. She then asks you, "What type of joint is my shoulder?" And then what are you going to tell her? Great. Great. You guys nailed it again. It's synovial ball and socket, so we kind of already talked about all of those joints, so I won't go back over it again. And then we still have Susie one more time. She says she's eager to leave the emergency room so she can go study for her anatomy exam. And Susie asks you one more burning questions. She says, "I'm having a hard time understanding the plane joints. Can you give me a few examples?" What are you going to tell Susie to help her get an A on her anatomy exam? Great. Good job, everyone. We had 64% got that it was D. Couple people were kind of torn between A and B. So yeah, your wrist and ankles are plane joints. So they do that like gliding and sliding motion. So you can kind of think of like an airplane, like sliding down, gliding onto the runway, or taking off in a smoother motion. Um, but yeah, those are for your ankles and wrists. Your hip, like we talked about, is a ball and socket. And then doing a bicep curl with your elbow's a hinge joint. So those are why those are incorrect. Does that make sense to everyone? Cool. Okay, and that's all I have for you guys for questions. So these are my references.
All right.
Um,
All right, Taylor.
question.
Very, very nice presentation. And I think everyone enjoyed it. Um, we open up to questions. Anybody that would like to ask Taylor a question, even her favorite color or what book she's reading at the present time, or how do you get to medical school? So I see Sammy is on, got his hand up, so go ahead and unmute Sammy and ask your question.
Okay, so my question. Oh, by the way, hi, nice to meet you all again. It's great to see you all again. My question for you is, so I have been, shadowing and interning, and hi, and my question to you is, what do you think is the best way to get through, of course, pre-med and med school, and what should you tackle first through it?
So the question is how to tackle being a pre-med and medical school, kind of like at the same time, or?
Not at the same time, but like getting through it, just like the journey itself, you know. So,
Yeah, for sure. I would say I went to a smaller school, a smaller college, so it was really nice. Like all the professors knew everyone by like their first name. They had open office hours, so like if you had any questions, you could just they were like, "Hey, yeah, like if my door's open, come right in whenever." So that was really helpful to me because it provided a lot of like support, and also made it so like if I was really struggling, I could come in whenever and get my questions answered right away, and it made me not feel like lost, I guess. That was really helpful. I think also just like trying to be really, what's the word for it? Um, intentional with your studying. So like when you're studying, really try to do like active studying and really focusing. And so like when you're studying, you're not thinking about everything else. And then that also makes it so that when you're not studying, you're not
Mhm.
studying. Like you're relaxing, you're hanging out, you're doing stuff with your friends, you're like, I don't know, playing video games or you're out like playing sports, whatever makes you happy. Just make sure that you figure out that balance of studying and then also like enjoying yourself because like you need to do the things that make you happy so that you still have like your passion and your motivation to like think about like if you want to be a doctor, like the kind of doctor you want to be. Like you don't want to become like burnt out and grumpy, so then you're not like a good doctor to your patients. So I think just like take care of yourself and then like don't be afraid to like ask questions and put yourself out there. If you're struggling with content, like go get help.
Okay.
I had to go get help a lot. So
Okay. Thank you. I remember, and yeah, I did ask a lot of questions. I think you can ask them. They remember. I used to be very passionate about my questions I think it was last year. Yeah. And it's been pretty good so far. Our school and the hospital near us in the southern region, Mississippi, it's UMC, University Medical Center, and we have like MedCore and stuff like that. But I'm still depicting. I got accepted to a lot of colleges and a good bit of scholarships, but
yeah,
I don't know where to go. I honestly don't. I'm still in that process too, so
sure.
gonna pray about it. But thank you so much.
Yeah. Yeah, of course. Congrats on getting accepted. That's awesome.
Thank you, and it's great talking to like-minded individuals too. So thank you so much.
Yeah.
We had a couple questions in the chat. Taylor, how do you remember the differences between all the osteological landmarks on bones that have minimal differences, like tubercle versus tuberosity, and meatus versus fossa, etc.?
Oh gosh. I think for me, it was a lot of like rote memorization. Like you kind of just have to sit down and I don't know if you guys have like bone models, but for me, I'm like a very hands-on learner. So if I like our school had like labs and they had like bones that you could go in and like feel it, touch it, and like that kind of helped solidify it in my brain. And then like get like a study buddy and just like quiz each other too, and then make sure to tell them like I want you to tell me like if it's tuberosity or tubercle, like I need the specifics to be correct and just doing a lot of like active recall and quizzing yourself.
I will say too, sometimes in atlases or if you go, libraries are an amazing tool. Libraries offer free resources. I'm not sure about anatomical models. It depends on your library. But if you can go to the library and get like an anatomical text, oftentimes, or an osteology text, oftentimes in the beginning, they'll define those terms for you. Tuberosity, condyle. A lot of these places are protuberances, like processes, things that jut out because they are attaching to something like a tendon or a muscle. And depending on where it is and how big it is, that's where tubercle or tuberosity comes from. Excuse me, fossa is going to be more of a dip, like a valley. So again, I would, you can always, and that's another thing too, you can kind of take a look up at the different definitions. I wouldn't worry too much about what's this versus this, right? It's just I would worry more about if like going to the atlas and taking a look at the different landmark names versus um, what's the difference between tuberosity and tubercle. And I know we have a little we're trying to gonna stay on time for our next session. So I will say if we have any questions for Taylor, Taylor, do you plan on hanging on till the end?
Yeah, I
for
can
like
stay on till then.
school questions. If she's able to stay on, then they can stay on till the end. And then let's see. We have, do we need to know major landmarks, specific landmarks on major bones like the femur and the humerus? I would say that we put together our practical and our questions based off of the materials that we give you. So anything in the lectures are fair game, lectures you watch from last year, any questions you have here, any atlas information that we have on our website, you can find a histology and an anatomy atlas there. Any resources like that we have on our website are fair game. Dr. Peterson, is there anything else you want to add that I'm missing for resources?
Just to remind everybody that you will have, or you have already, access to the toll tag software, and they have some really amazing kind of practical quizzes. I see that's a question in the chat as well. And they can be very, very helpful. You just hover over something and it will pop up with the name of that muscle or that landmark. And that can be a really good way to test yourself if you don't have a study buddy or can't find someone at your school to help you out in that regard.
And if you make sure you have access, make sure you have access to the classroom and make sure you have access to Toltec. You should have got that when you registered. If you didn't, email us or send a message in the chat and we can look into it. One last question I'll answer very quickly. Bone classifications, long, short, irregular, etc. Taylor covered based more on shape or general function purpose. Yes. So yes, they are based on shape and they are based on general function. And again, they have a lot of major differences depending on how they've developed, but we know that we develop so that we function in certain ways. So that is a very good question, and yes to all of that. Okay, and then I will have, and then when we, I would, let's save the questions like how do practicals work and things like that, and questions for Taylor for the end when we have a little bit more time. Okay. So let's introduce our next person, and Rena, I'm going to send you a personal message through the chat.
Okay. So Taylor, yes, thank you. Our next presenter is going to present on the histology of cartilage and bone. Her name is Sara Jafri, and Sara graduated from the University of Michigan, go Wolverines, okay, with a Bachelor of Science after double majoring in neuroscience and Spanish. She subsequently earned her Master of Science in Applied Anatomy from Case Western Reserve University. She is currently a second-year medical student at the Sidney Kimmel Medical College at Thomas Jefferson University. In her free time, Sara enjoys reading, drawing, trying new coffee spots, and spending time with her friends and family. So grab a cup of Joe, and Sara, it is all yours.
Thanks for that wonderful introduction, Dr. Frank. Glad to be back. I love the Anato-Bee group. You guys are always amazing. Nice to see some familiar faces too. And also, Taylor, thank you for that great gross anatomy talk. I think it was really nice and love the Susie questions. Before we get started, I will say I am losing my voice a little bit, so I apologize if you guys have any difficulty hearing me. If you have any questions, please put it in the chat and I'll be happy to answer them. I'm going to go ahead and share my screen really quickly. All right, let's see. Can you guys see that okay? Yes, okay, beautiful. I'm gonna take out a laser point. And can you guys see that as well? Perfect. All right, so this talk is gonna be specifically on the histology of cartilage and bone. It's gonna be very similar to the last presentation where it's a Q&A format. These questions are based off of the histology talk that a wonderful Haley Long gave last year. I hope you guys got a chance to check it out beforehand. If not, we'll go through it together. I'll hold your hand. But please do check it out if you get a chance later. All right. And again, if you have any questions throughout, please do put them in the chat. So just for our learning objectives for today, we're going to talk a little bit about cartilage. We're going to talk about specific bone cells, and then also different types of bone, and differently from how Taylor talked about them. And here's a link for last year's talk if you're interested in that. All right. So I'm going to start with like a case approach, and then we'll go to questions. So for your first case, you have an elderly patient who has a history of intervertebral disc disease and is continuing to experience back pain. So as a nice little warm-up reminder from the last talk, if we're looking at your whole skeleton and we zoom into the spine and your vertebral column here, blow it up here, you have your bones, and then in between each of them, you have these little intervertebral discs, the little blue parts. All right. So those are made of cartilage. And the type of cartilage you find in those intervertebral discs is the same type of cartilage you would find in the pubic symphysis. So again, if we're looking at the whole skeleton here and we zoom in on kind of that hip bone that we were talking about before, you see it like this. And then you have the two pubis bones, and they're both conjoined by the pubic symphysis, which is also made of cartilage. So my question to you is, if we were to take a histological sample of that cartilage, this one specifically is from the pubic symphysis, what kind of cartilage would it be made by? The same for the IV discs and also for the pubic symphysis. And if we can get a poll, that'd be great. Thank you. I'll give you guys a minute. All right, responses are looking pretty good. I'm going to go ahead and close the poll. And let's show you guys the results. So it looks like the answers are a little split, but for the most part, you guys did get it. So this is fibrous cartilage. And so if we take this like schematic, almost like a cartoony picture of the same image and kind of lay it on top, you can kind of see better. So fibrous cartilage is going to have the cells, the chondrocytes, arranged in rows like this. I do see like another popular answer was hyaline cartilage, which I kind of anticipated. So let's compare hyaline cartilage and fibrous cartilage really quickly. So fibrous cartilage is what we just saw with the IV disc and the pubic symphysis. And you can see those chondrocytes are in very nice rows, very organized. Whereas in hyaline cartilage, they're more in groups. You don't really see them like lined up. They're all kind of like clustered together. Another big difference that you can see is, as the name kind of implies for fibrous cartilage, you're going to see fibers, which are like these thin, like little lines that you see that you will not find in the hyaline cartilage. Okay. All right, great, you guys. Let's go on to our next question, or our next case. So your next patient is a 7-year-old boy. He says he was playing outside when he felt something bite the outside of his ear. So beautiful ear. Let's look at some cartilage from this area if we were to take a histosection from his external ear. So this is kind of what we would get. And my question here is, what would we not find here? Would it be blood vessels, chondroblasts, chondrocytes, or elastic fibers? Open up the poll here and give you guys a minute to figure that out. All right, looking good. So let's go ahead and close the poll and look at our results. So again, we see a little bit of splitting amongst the answer choices, but for the most part, you guys did get it right. It is blood vessels. And so again, I'm just going to put another picture of like a cartoony schematic on top of this. But the main point here is that cartilage is avascular, which anytime you have a before a word, for the most part, it means not. So it's not vascular, meaning it does not have blood vessels. So in this picture, what we can see the chondrocytes, which are these little guys all over. You can see the chondroblasts, which are kind of lower down here, a little flatter. And then we have those really nice elastic fibers, which are these lines kind of going all throughout. This is similar to the hyaline cartilage that we looked at before, in the sense that you do have your chondrocytes and you can have chondroblasts. The main difference here, though, would be elastic fibers you would not find elastic fibers in the hyaline cartilage. but both of them would not have blood vessels. I see a question in the chat. So I see, does cartilage usually get nutrients from diffusion or from another method? So cartilage is not living tissue. Which is the reason you don't have blood vessels there, unlike bone, which we will talk about in a little bit. That definitely needs nutrients, and that's why it has the blood vessels going through. All right. All right, let's move on to our next question. All right. This is a nice and easy one. So what is the most common type of cartilage, if there is one that's more common than the others? All right, cool. Let's go ahead and close the chat. The poll. Thank you. So our most popular answer was hyaline cartilage, and our second most popular was elastic cartilage. So we've looked at both of them so far. The most popular is actually going to be hyaline cartilage. So this is it's another name for articular cartilage. So whenever we're looking at long bones, which are the bones you see in your arms, your legs, even like in your hands and your feet, you'll always notice at the caps of them, they have this like cartilage to basically prevent, so you don't have like bone on bone, because if you rub bone on bone, that would be very, very, very painful. So this hyaline cartilage that we have here is basically protecting your bones from each other, from that friction, from that force that you kind of get. Okay.
Sorry, Dr. Peterson and I might be going thinking on the same train here. Do you want to go ahead, Dr. Peterson?
I'll just jump in and say, first of all, Sarah, there are some questions in the chat that I think are really important to get answered on the recording, but I want to go back to something that you said and just make sure that everybody understands that cartilage is a living tissue. There are live cells embedded in a matrix gel-like material, but because their metabolic activity is so low, the rate of diffusion from the surrounding connective tissue wrapping is enough to keep those cells alive. But what it does mean is that when cartilage is damaged, it takes a very long time for that cartilage to repair. And oftentimes it will not be as strong as it was before the trauma, which is why people go in and have those cartilage tears surgically repaired.
Yeah, that's exactly what I want.
Sorry, I did.
No, it's all good.
Yeah,
I 100% what Dr. Peterson said. I'll also just add the one thing she said is usually that you have like periosteum on a bone. You can have like perichondrium that covers the cartilage, and that will contain blood vessels to reach the cells. The only thing I wanted to add was if it's in a synovial situation, the synovial fluid can actually bathe the cartilage and get nutrients to it as well. We're getting a little nitty gritty, but the main point is, yeah, it's a living cell, but the turnover is extremely low, 100%. Sarah, I don't know if you want to get a chance to answer this question. If you were given a simple color histological image of hyaline cartilage and elastic cartilage, how could you find the difference? How can you tell the presence of elastic fibers in the elastic cartilage?
Yeah, so off the top of my head, I would say there are different types of stains that you can do for the cartilage. So the most common type of stain that we tend to do in histology is like an H&E stain that you might have heard of. It's hematoxylin and eosin. So that's kind of like that pink and purpley stain that we see. You can do a different type of stain, which is called an elastin stain. And that stain specifically will stain the elastin fibers to like show you where if there are fibers present, and that's one of the
Can you go back to your elastic slide, elastic cartilage? I think, did you have, this might be, looks a little purple, but it may be an elastin stain. Usually it shows up really blue. But go ahead, Sarah.
Yeah, I was just going to say that.
Yeah.
All right.
Can I
Cool.
jump in, Sarah? Would you mind?
Yeah,
Is that
absolutely. Please.
another way for all of you on the watching in person and then on the recording is that we also look at the background, and that's the matrix material. And if it's what we call, and maybe if you went to your side-by-side comparison right there. So one of the things you want to take note of on the left-hand side of that image is the hyaline cartilage typically, and I want you to go down towards the lower part of the image where it's really light colored pink. We describe hyaline cartilage as having a homogeneous matrix in the way that it's stained. So it's all a similar color. Up above that light pink area, you see all of those cells, they're actively dividing, and that gives a different staining property to the cartilage. But if you were just looking at hyaline cartilage, you're looking for a really all the same color type of matrix. As Sarah pointed out with fibrous cartilage, you're looking mostly for those chondrocytes to be in those stacks. And then with elastic cartilage, the difference there is that the background is not homogeneously staining. It's what we call hetero, meaning different staining properties. So you can kind of see there's some light, there's some dark. So maybe that's another way to think about a clue to help you know what you're looking at for cartilage.
Fantastic. Thank you. And I think I see a comment that somebody put in the chat that elastic fibers do look a little more haphazard. I would, for the most part, agree with that compared to fiber cartilage. Like we said, the chondrocytes in the fiber cartilage, if I go back here, they're going to be in the stacks, but you can also see the fibers are a little more organized in between those stacks. Whereas here, because the chondrocytes in elastic cartilage aren't really as organized, the fibers are just kind of around them. All right,
And
wonderful.
that smooth appearance.
Answer.
Yeah, that was. Thank you, Sarah. That smooth appearance, we call it glassy. We think hyaline cartilage looks glassy in appearance, if you want another term to put with that. So yeah, this is really all really great conversations. We're learning together.
I love that. All right, I'm going to move on to the next question. Let's see. We got that. Okay. We already talked about this one, and I think you guys, for the most part, got hyaline cartilage. Great, we talked about that. For this next question, I'm going to have 3 questions in a row. Instead of doing a poll for each of them, I'm going to ask you guys to just put your answers in the chat, A, B, or C. I think it'll be easiest this way. So this histological tissue that we're looking at here is from bone. And you guys already learned in your lecture that there are 3 major cell types within bone. So there are osteoblasts, osteoclasts, and osteocytes. And so I'm just going to ask you about the function of each of them. So which of these 3 options is mainly responsible for making bone, for creating that bone? You can put it in chat either to everybody or to me specifically. It's up to you. I'll give you guys a minute. All right, awesome. I'm not going to give you the answers until the end, so just hang on for a second. Our next question is, which of these is mainly responsible for maintaining bone? And it's also the primary bone cell. All right, awesome. And finally, which one of these is primarily responsible for resorbing or breaking down the bone? Basically, which of the 3 have you not chosen yet? Just kidding, no. All right, looks good. I think I have answers from just about everybody. So wonderful. Let's talk about it. So yes, you guys did get, I think everybody got all of them right. These are, again, the osteoblasts. Their function is to make bone. Osteoclasts are responsible for breaking down the bone, resorbing it. And then osteocytes are the main bone cell, and they're just maintaining the bone. A trick I learned when I was learning these was anytime you see a blast cell, it's making things. And so things are born from the blast cells. Anytime you see a class cell, it's killing stuff because it's breaking it down. And then cyte just means cells. So that's typically the primary functional cell of whatever we're talking about, like osteocytes or chondrocytes when we were talking about cartilage. And that tends to be a good rule of thumb to go through anatomy with. All right, let's talk a little bit more about these. So again, this is a schematic. I really like seeing a schematic right next to the actual histological picture. This is nice because it kind of outlines the cells specifically a little more. So here you can see those osteocytes. They're kind of singular ones and with the like connective tissue around it. Whereas the osteoclast is kind of like a bunch of nuclei in one cell. And then osteoblasts, again, singular cells with singular nuclei, but they're all kind of clustered in little regions. So if we go to this cell, this picture, it kind of shows you each of those cells a little better. So we can see that we have the osteocytes, again, those primary bone cells within the bony matrix, responsible for maintaining the bone. And you can see that in this schematic really nicely. It's below the basement membrane layer. Whereas the osteoblasts and the osteoclasts are both going to be outside in like the more of the marrow space. This one I think is really nice because it shows you that the osteoclasts are multinucleated. You can see these little pink nuclei. And so if we look at the osteoclast here, you can see this whole thing is an osteoclast, but like you have all those little nuclei within it. Whereas the osteoblasts, each of them only have a single nucleus. And so it's a little harder to see the rest of the cell here, but you can see that the nucleus is that really dark staining part. Does that make sense, everybody? Any questions there? No? Okay, great. Let's go to our next question. All right, so what kind of bone do osteoclasts primarily resorb? We know that they do the resorption, but what are they resorbing? Is it bone that's in the process of being formed, bone that was just recently formed, bone that's been damaged, or the resorption of bone is a random process? And we'll do a poll for this one. All right, great. We do have quite a bit of responses, which is wonderful. And for the most part, you all got it right. The answer is bone that has been damaged. So osteoclasts, again, they're looking for things that are damaged and what kind of needs to be cleaned up and taken away so that the rest of the other cells can either do their function or the bone can just be healthier. You don't really want to be taking away bone that was either just formed or that is being formed because it hasn't really had the opportunity to do what it needs to do. All right.
I will say, Sarah, for just kind of like they actually do go through a process too with bone being formed.
During ossification.
Yes.
Yes.
Yes. So, but yeah, I think again getting into the nitty-gritty.
Yeah, I thought for the Ellos for this talk, I would want to keep it on the simpler side, and then hopefully during embryo we'll talk a little bit more about ossification.
Okay. Yeah, I think that's good.
Cool. All right. All right, so here I have two pictures. One is going to be compact bone and one is going to be trabecular bone, also known as spongy bone. So I just want you guys to tell me which one specifically is compact bone. We can do a poll for this. All right, so let's go ahead and close the poll. So our answers are more split than we've seen in previous questions for this question. So the answer is A. This is compact bone. This is spongy bone. When we're talking about compact bone, you're going to have osteons, which are kind of like these circular structures. If we look at like these, there's a lot more organization to it, and it's also the connective tissue part of it like is a lot denser. Whereas in spongy bone, you can see it has a very spongy like look, as the name suggests, but also you don't see the osteons, which are like very nicely organized concentric circles around the blood vessels and the blood system that's going on. If we look at this picture, it might be a little easier to kind of see what I'm talking about. So this middle part, all this is spongy bone, that trabecular bone, and compact bone is where what you're going to see like along the outside edges of the bone. And so you can see the spongy bone is very hollow, I guess is a good way to describe it. It's not going to have a whole lot of weight. It's not going to be as densely packed. Whereas the compact bone that's on the outside is going to be densely packed because you're trying to make sure that you have enough protection. This is somewhere I would say like structure definitely follows function because the spongy bone is on the inside, and that's also where like the blood supply is going through. You want to have cavernous regions that the blood can go through. They're like spaces that they can go through. Whereas along the outside, you want it to be hard, not rock solid, but pretty solid for protection purposes. So if we go back to these slides, this kind of aligns. This is the spongy bone. This kind of aligns with what we saw in the gross picture. Whereas the compact bone, again, is just a denser look overall. Does that make sense? Yes. Okay. Good. All right. And I believe that's it for me. These are my resources. If you guys have any questions, I'd be happy to answer them.
Okay. Sammy, you have a question? Go ahead and unmute.
Yes. So, let me. Yikes. Okay. So when it comes to like, for example, and this is just a question that one of those last year questions, but so like a patient with sciatica or some older person like that, and they're hurting right, left side of their body, would it be something to deal with the cartilage, or is it just nerves? In
That's
that case.
That's a great question. So sciatica specifically is more of a clinical diagnosis. It's kind of, it's not necessarily a specific disease. Basically, sciatica is saying that there's something impinging on the nerve, kind of like compressing it, pressing down on it. And because of that, you do feel that shooting pain down, like specifically down your leg, because your muscle is down in the leg or the foot. They're not really getting that innervation properly. And so we do tend to say that sciatica is like I said, a clinical diagnosis, not necessarily, it's not easy to narrow it down to any one thing. You would have to do a little more of a workup to be like, is this due to like the intervertebral discs like blowing out and kind of bulging out of where they are, or is it due to more of the bone degenerating and because of that? So it could be a little bit of everything. So you do have to do your due diligence and do a little more work with that. But great question, Sammy. Hope that answers it.
Yes, ma'am. Thank you so much.
Of course. Happy to help. Anybody else?
Adelaide had asked a question. How do haversian canals impact the structures of either compact or spongy bone?
So as far as I recall, and I don't know if the embryo lecture is going to talk about this at all. Brian, if you get into this in that. No? Okay. So basically your bone is forming around, and faculty, please feel free to stop me if I say anything beyond the scope of what they need to know or incorrect. But basically the bone is forming around your blood supply. And so for haversian specifically, I don't believe it gets to the compact bone part because the compact bone is more around that like outer perimeter. That's going to be more in the spongy bone region.
Yeah, so we'll have so for spongy bone, they don't contain the Haversian canals. They'll still build bone, and then osteoclast comes in and remodels, and they build and they remodel to form the spicules, but they're surrounded by bone marrow, right? So Sarah had shown that picture of like the cut in the bone itself. Yeah, right here. But because of those spicules and how they're formed, they're basically bathing in nutrients the whole time. Um, so, so the spongy bone doesn't have Haversian canals. Those trabeculae don't have the canals. But this is how I like to think about it. You have like especially in a long bone, you have your epiphyses, and then you have the middle part, the metaphysis, right? So what's going to happen is during development, blood supply comes in. It kind of tells those areas, okay, I need you to start making bone. So then it'll go through the whole process of ossification. And I'm going to save us again because we'll talk about this a little bit later when we get more into depth of this process. But that's also again where we get these Haversian, and they have Volkmann canals as well that are perpendicular to the Haversian. But just like kind of how we're saying in the chat, compact bone, the Haversian canals are there to supply those osteocytes. So in the center of those, do you have an osteon or a, here we go. So see, yeah, that's this area that Sarah just alluded to right here. That's a Haversian canal. So it's going to contain your nutrients, and the little darker area spots around it are going to be your osteocytes trapped inside the calcified bone. And they're going to send little spicules out called canaliculi. So these little other kind of areas within the bones, little canals that will connect to this canal with the blood supply in it, and it allows that nutrients to communicate to the osteocytes in their little lacunae. Um, but again, yes, it does have a lot to do with bone formation around the nutrient supply, and that Haversian and Volkmann canals contain arteries within them so that they can supply the osteocytes within the lacunae around them. Is there anything I'm missing, Dr. Frank, Dr. Peterson?
I was just gonna reiterate that over on the other side, at image B, so there is bone marrow around all of the spongy tentacle-like trabeculae. So a lot of vocabulary here, but each of those tentacles is covered with a thin connective tissue wrapping, and that's where the blood supply is for those tentacles. So they're not really getting oxygen. It's not being exchanged between the bone marrow and the spongy bone. It's the endosteum. It's that connective tissue wrapping where their own individual blood supply is. Within the bone marrow, though, really important for you to understand, even now, that that's where red blood cells, white blood cells, and platelets are forming. And knowing that, it really helps you better understand the function of the epiphyses of the adult bones in the human body, as well as what Sarah mentioned, the vertebrae have a core of bone marrow. So you're also making new red blood cells and white blood cells in your spine every single day, which is very cool.
Very
So I
cool.
think that pretty much covers it.
Okay, do we have more questions for Sara? And Rashab, were we able to answer your question on why don't spongy bones have Haversian canals? All right, I got the thumbs up. Excellent. Okay, Sara, before I let you off the hot seat here, let's just make sure nobody has any other burning questions for you since we have a few minutes. Okay, Adelaide had, as the epiphyseal plate fades and it becomes more of an epiphyseal line, does the kind of bone change?
And maybe, Sarah, what we say here is this whole story is coming in a future tutoring session. And I'll just so that you don't leave Adelaide feeling like you'll have to be in suspense for all of that, we'll just say that at the epiphyseal plate, it's cartilage, and that allows the bone to extend in length. And then as we approach puberty, that cartilage is going to become calcified and it slims down to a line. And that's why you can't get any taller after puberty. Sorry to say, but that's what's going to happen to all of you. But we'll explain all of that in a lot more detail in a couple of weeks.
Hey, great question. All right. Okay. If there are none, we will let Sarah kind of off the hot seat and excellent presentation. Thank you for sharing your knowledge with us this evening. And that brings us to our final presenter, which is from our very own Drexel University College of Medicine, Brian Nguyen. And Brian is from Fairfax, Virginia. He graduated from George Mason University in 2019 with a BS in biology and Eastern Virginia Medical School with an MS in biomedical sciences in 2021. He is currently a second-year medical student at Drexel, exploring the specialties of hematology, oncology, pediatrics, and surgery. So in his free time, he enjoys playing video games and cooking and loves listening to electronic dance music, or EDM. I had to look that up. Sometimes in the anatomy lab. His favorite unit in anatomy is abdominal and GI anatomy, a really interesting and digestible topic. So I am sure that your presentation is going to be both interesting and digestible. So with that, Brian, I give you the floor. And
All right, I appreciate that introduction. Yeah, what can I say? I like EDM. I like the music that makes you move, and that's why we're here to learn anatomy and physiology, right? So, with that being said, I'm going to go ahead and share my screen. We have some exciting things to go through today with gastrulation. Can everyone see the slides? Dr. Frank, can you get a thumbs up? Okay, excellent. All right, so I have no financial interests to disclose, and my material is based on your lecture presentation that you received from Lily Zhang from TJ. All right, so with that being said, here are your learning objectives. We have three of them. We're going to talk about gastrulation, its formation of the germ layers, and those three germ layers and those different tissue types that it makes. So we'll start off with just a brief overview of the, honestly, embryology. It is one of the hardest topics to get, whether it be in medical school or just learning it for the first time. Okay, so just to sort of get an overview, right? Here we have our little diagram of a female reproductive organ. We have our ova right here, ovaries right here, and then our fallopian tube and our uterus right there in the middle. Okay, so first things first, we have our issue of fertilization. That's when mom is going to release that ovum, dad's going to donate the sperm, and then they're going to fuse. You're going to get that acrosomal reaction between the sperm and the egg. The egg is going to complete meiosis too. And then we're going to finally get a complete zygote with diploid chromosomes, right? That's going to undergo mitosis. It's going to divide, divide, divide. At that point, we want to remember that those cells are totipotent. They are totally potent, able to turn into any kind of cell type. That's a key clinical part to think about when you're thinking about making twins, okay? Now it's going to divide until we get a ball of cells called a morula. Now that morula, then it's going to turn into a pluripotent stem cell where it's going to divide into most, but not all of the types of germ cell layers that we'll be talking about. That morula will divide, divide, and divide and hollow out. So we have like a sort of lump in the middle, this sort of empty cavity, and this sort of shell of cells around that we call our blastocysts. And that inner part, that's that empty cavity, we call that our blastocystic cavity. That's going to embed itself into the walls of the endometrium around week, or sorry, not week 7, or sorry, not week 7, around the end of the first week. And then we're going to have the differentiation of the cell layers. So remember, we had that outer cell wall or outer cell mass. That's going to turn into a layer of cells called our trophoblasts, which specializes in supplying blood and nutrients to our developing fetus. And then we also have our inner cell mass. Those are going to develop into 2 specialized cell layers that we call our hypoblast and our epiblast. Okay, so we can see here in this image, the hypoblast and the epiblast sort of make these 2 layers of cells. And then what's going to happen is that epiblast is going to divide and make sort of like another pocket in the middle between them. And that's what we call our amniotic cavity. And then we also have the cells of our outer cell mass that we call our trophoblasts. They are going to also divide and sort of make this extra ring that we see here on that bottom right image. It's going to make like a sort of another cavity. And now at this point, we have 3 different cavities forming at the end of our second week. This is with cells dividing inside cells. The image I want you guys to think about is sort of like a bubble inside another, next 2 bubbles attached to each other inside a larger balloon. And that larger balloon is going to have that right there. That is going to be made up of our trophoblasts. That's going to be our chorionic cavity. And then we have that blastocystic cavity. And then we have our amniotic cavity. 2 bubbles stuck to each other inside a larger balloon. Okay, now we're going to move to the end of week 2, where the epiblast is now going to develop a specialized structure. Dr. Frank, can I get a pull up? And I'm going to move on to this first question. So at the end of week 2 of human development, the cells along the middle of the epiblast begin to divide, forming an elevated midline of cells. What is this structure called?
Brian, can you see the poll results?
Yeah, we're at 60. Let's get a couple more answer choices in.
I've already
And push
stopped the
the.
poll. I've
Oh,
already stopped the poll.
oh, perfect. Okay, okay. All right, so let's go ahead and move on. It looks like a majority of us chose the correct answer. So that is, yes, the primitive streak. So just to very briefly go over the other choices, remember our chorion is going to be part of that other cavity. Our primary yolk sac is, again, another cavity that we talked about. Our connecting stalk is going to eventually form our umbilical cord. We didn't really focus on that yet. And our syncytial trophoblasts are another cell cell is what our trophoblasts will specialize into alongside our cytotrophoblasts. That's not what we're talking about here. We're talking about the primitive streak. So that primitive streak is going to be, if you were to sort of imagine inside the amnion, where you just see this like lump of cells dividing, what you're going to see is this sort of, I like to think of it as almost like a shark's fin. and it will divide and divide and divide and move closer from the caudal end to, or your, I guess, your foot end, your lower end, to the cranial end, the top of our head, and divide and divide and divide until you get sort of like this ridge line of cells. Now we call that the primitive streak. Now that's going to divide until it reaches an area just behind the precordial plate and divide into a signaling center that we call the primitive node. And now that primitive node is going to release a very important signaling factor called FGF, also known as fibroblast growth factor. And that's going to drive all the signals to, that's going to signal our cells to begin a process that we called epithelial mesenchymal transition, also known as EMT. And that's basically where our cells detach and start moving into that primitive streak to form our layers, to form and make our 3-cell layer embryo that we call our trilaminar disc. That whole process is called gastrulation. Now, it's a little bit of a confusing thing to sort of think about how the cells move. First off, we have that primitive streak, that sort of ridge line of cells, right? Now, what's going to happen is after that primitive node is going to release FGF, those cells are sort of going to move downwards and then inwards. And then if we look at this picture on the left here, we see the epiblast and the hypoblast are kind of sandwiched. That's that bilaminar disc. As those layer of cells from the primitive node go from here downwards and inwards, it's going to fill a third layer, almost like I like to think of it like it's stuffing a pita pocket. And that's going to create our 3 germ layers, which we'll talk about after we go through this question. So can we get another poll? And the first cells to migrate into the primitive streak will become which of the following? Okay. All right. So it looks like a majority of us chose C, the endoderm. Okay, so let's go through these choices. And I want to point out that a couple of you guys chose the hypoblast. So let's go ahead and go back to just very quickly, just that image real quick. Remember that first layer of cells, as they travel inwards, they fill the space between the epiblast and hypoblast. So it's going to sort of like fill it up like you're sort of stuffing, well, quite literally a pocket of cells. Now, eventually, those cells will replace the ventral side of that hypoblast. Those endoderm will replace some of the hypoblast, but those first cells that move in are going to be our endoderm. Okay, so let's go ahead and talk about that movement that we talked about. So we have our cells that move in. That's going to be our endoderm. And then all those cells that made up our primitive streak are going to, well, not be there anymore. And as a result, what we're going to have left is this sort of gap, this sort of trench, this empty space running up along the epiblast, leading up to that primitive node called the primitive groove. Now, at this point, more cells are going to keep moving forward and keep migrating as that primitive node is going to release more and more FGF. And we call that second layer that moves in the mesoderm. And then we have another layer that's not going to move in. That's our that remains part of the epiblast. That's going to mature and become our ectoderm. Okay. So with that being said, we started we have our 3 germ layers that we made through this process of gastrulation as those cells are signaled by the primitive node to move from the primitive streak down inside and outwards to fill up the area between the epiblasts and hypoblasts. That is called gastrulation. So let's start talking about the structures that are derived from the ectoderm. Let's go ahead and get another poll question. Which are the
Brian, before you
Yes.
move, before you move on, I think there's some questions in the chat, and maybe we just take a pause and just kind of review what from the beginning of your PowerPoint. So let's put this in perspective for everybody that's going to watch this on the recording and or all of those tuned in right now. So can you go back to maybe even your very first slide?
Sure. So that's going to be this image.
Yes, please. So I just wanted to put this in perspective with a timeline. So from the time the egg cell is ovulated to when it meets a spermatozoa and fertilization can occur, everybody should know that's about a 24-hour window. Once fertilization occurs, it's going to take about the remainder of that very first week for our dividing cell mass to actually reach the uterine cavity. So this is week 1 after fertilization occurs. And I think Brian talked you through that. There was a question in the chat that's pretty important. So as these cells, after fertilization has occurred, as they start to undergo mitosis, they go through everything that you've been taught includes mitosis in high school. So prophase, metaphase, anaphase, and telophase, and then they divide. But they're kind of encased in a gelatinous goo, so they're not able to expand in size. So the huge egg cell is just getting further and further subdivided into smaller and smaller cells within that goo. And it's not until there's actual attachment, which we call implantation, at the end of week 1 that that gelatinous glue goes away and the cells now kind of have a greater possibility for increasing in cell size and cell number. And in week 2, as Brian described, we're going to generate 2 layers of cells, and that is in week 2, so we call it the bilaminar disc, and that was the epiblast and the hypoblast that he referred to. And then I think, Brian, if you move on, so as we go through week 2, we're generating 2 cavities. So week 2, an amniotic cavity and a chorionic cavity. We still have our 2 layers of cells. So think of it as a stack of 2 pancakes. And what starts to happen at the end of week 2 is we're going to generate almost as if you were using a knife and cutting it through the stack of 2 pancakes. And I like the analogy that Brian used of stuffing a pita sandwich. So we start gastrulation at the beginning of week 3, and we have 3 primary germ layers. And it's really important that you know endoderm forms first, mesoderm middlemost layer, and then those cells that don't migrate through the groove become the ectoderm. So I think we've answered all of those questions, and I think we had a nice recap. So I'm sure now, as we move forward, Brian, with your questions, we'll get more responses that will be helpful to everybody watching the recording.
Sure. So, okay, so let's go ahead and go on with this practice question. Can we get a poll, Dr. Frank? Thanks. Okay, so which of the following structures are derived from the ectoderm?
It looks like Dr. Frank ended the poll, Brian. You want to talk
Okay.
them through that?
Sure. Okay. So, all right. So our answer was, and it looks like a majority of us chose C. Yes, that's going to be our skin. Our ectoderm is our most, we can call it our most superficial layer. I like to think this is our attractoderm. So this is what's going to be making up a majority of our things that are going to make you attractive. So that's going to be our skin, our physical appearance, our brain, our neurons, right? So that's going to be our nervous system as well as our integumentary system. Now, it also makes a couple other things. It makes our sensory epithelium of our eyes, ears, and nose. That's going to be our mucosal surfaces of our special senses. It's going to make our hair, teeth, and nails, as well as the retina, lens, iris, and cornea of the eye. Okay. Now, I want to point out something is that it also makes the adrenal medulla. Our adrenal medulla is important for making catecholamines like epinephrine and norepinephrine. Those are the hormones that make you move. You might know them as adrenaline, as opposed to the adrenal cortex. Okay, so that's something to keep in mind. The adrenal medulla is made by our ectoderm, not our adrenal cortex. Okay, so let's go ahead and get another polling question for this one. The ribs and the vertebrae derive from which germ layer? All right. So, okay, so if you chose A, that's the right answer. So let's go ahead and talk about all of these. So we have a tons of different mesoderms. So the thing is after we have our first layer of cells that migrate down the node, we have three more waves of cells that follow that make different parts of what we call the mesoderm. So our first wave that's going to enter is going to be our paraxial mesoderm. This one's going to make all of our axial skeleton. I like to think paraxial axial skeleton, right? As well as our skeletal muscles. So the muscles that you can physically move around, right? Somatically control. And then, so that's going to be our skull, spine, ribs, as well as our skeletal muscles. Then we have our intermediate mesoderms. These are going to be our internal organs of all of our, how we think along of the that we think along the abdomen. So that's going to be our kidneys, ureters, as well as our gonads, but it's also going to make the other half of our adrenal gland, our adrenal cortex. Remember, our adrenal medulla is made by our ectoderm. Our adrenal cortex is made by our mesoderm. Now, our lateral plate mesoderm, that's going to have two different components. We have our somatic. That's just going to be our limb bones and our limb bones of our appendicular skeleton. So like our femur, our biceps, brachii, our humerus, things like that as well. And then we have our smooth muscles and our splanchnic is going to be made up of the smooth muscle of our GI tract, our spleen, and then our serous membranes of our internal organs. Okay. So with that being said, the last layer we will go through, we'll end strong with this last question. Which germ layer is the embryological origin of the bladder? All right, so let's go ahead and close the poll. And all right, so last one was going to be our endoderm. This one's going to make our bladder. Okay, so we're going to finish off with what our endoderm makes. These are our innermost organ, our line, germ layer. So endoderm, internal germ layer, right? So that's going to make things like the lining of our respiratory system, our digestive tract, as well as our bladder. Now, our urinary system is split up again, kind of like our adrenal gland with the ectoderm and the mesoderm. Our bladder is going to be specifically endoderm, but you guys might have been thinking of our kidneys, ureters, and gonads. Remember, that's the other organs of our urinary system. That's going to be our intermediate mesoderm. So just a little bit of the nitty-gritty details, but you can see how they're going to trick you with this stuff. So with that being said, here are my references. It was a pleasure to be able to present to you guys today. I guess you guys have any questions?
Really quickly, Brian, before you kind of tag out and we get more questions, just generic, and I know Taylor's going to come back on and talk a little bit about what she did in her gap year and why. If you could just go back 2 slides, I just want everybody to get a sense that that one, not this, I'm sorry, one more slide where you had the different mesoderm. This is a really important slide and it's really complicated, but let's go ahead, you use your cursor and let's just point out some of the really important landmarks here. So can you show them where the notochord is directly below the NT, which is the neural tube? So the notochord directly below it is a really important structure of the mesoderm. So I wanted everybody to understand that. And it is on, as we move from the midline, this is mesoderm. Closest to that notochord then is our paraaxial mesoderm in bright red. So you can see that little cartoon part of the illustration. And it, as Brian already suggested, the paraaxial mesoderm is going to give rise to the dermis of the skin, as well as the ribs that are going to protect the heart. And it's going to give rise to our vertebrae, which are going to protect the developing spinal cord. The intermediate mesoderm, if we move just slightly out, those are those orange ovals. Brian did a nice job of explaining that. And then most lateral to the midline of our stack of 3 pancakes. So move out to the very periphery. We have this lateral plate mesoderm. And Brian, if you would just go to the far right there and make sure they understand, it's dividing into a splanchnic. The root word splanchnic means having to do with organs, and then the somatic mesoderm. And why that matters, and everybody listen to this really carefully. Splanchnic having to do with organs, that layer is going to give rise to connective tissue and smooth muscle of hollow organs, where the somatic is going to give rise to connective tissue and skeletal muscle of our limbs. And so that's a really important and significant difference. Smooth muscle, very different than skeletal muscle. Skeletal muscle under voluntary control, smooth muscle is not. So that is really important. And this is a very important slide to refer back to. Brian, thank you so much. I thought you did a great job. That's really complicated information.
Thank you so much, Dr. Peterson. So I can try to take a stab at some of the questions in the chat. All right, so we have one question that is, why is the adrenal cortex made in the more inner germ layer? Guessing you mean the intermediate mesoderm in terms of the adrenal gland and the adrenal medulla. Okay, so remember that our adrenal medulla is going to be made up of our ectoderm, and then we have our adrenal cortex that's going to be made up of our intermediate mesoderm. As far as the why they're made up of 2 different germ layers, that has to do with I want to say the development of neurocrest cells. Can I phone a friend here, Dr. Peterson?
Indeed, and they're not there yet, Brian. So we'll just, say that this is a complicated gland that has two different regions, two different cell types that have two very different functions. And as in Sarah's presentation, as she alluded to, as we did in the very first tutoring session, the form follows the function and the function represents the form. And all of this will be explained in embryology segments in future tutoring sessions. So stay tuned for that. So great question though. And we'll leave you in suspense for just a couple weeks.
I know we have like 15 minutes, so I want to give an opportunity for those students who asked questions earlier on about Taylor's gap year, if they want to ask Brian, Sarah, and Taylor questions. We did also, Adelaide, I saw you had questions about practical exam setup. So I'm happy to, or we are all happy to answer that as well. I think quickly before we jump into student questions, Adelaide, do you you can answer in the chat or you can unmute yourself. But just let me know if I'm answering your question. So the practical exam setup that we have with Anato-Bee parallels very closely to what the medical students or our osteopathic students do in their own exams. So it's a donor-based exam. So for this first local exam, it will be image-based. So you will have donor images that are labeled. But if you make it to the regional competition, it's in person and we will have a donor exam. It's multiple choice. Some institutions like Drexel don't do multiple choice. They do fill in the blank. Yeah, for all of you, like Jefferson, I'm at Jefferson. I used to teach at Drexel. I'm at Jefferson now. We do multiple choice. I believe VCOM also does multiple choice. Correct me if I'm wrong. But basically you go in and their structure is tagged, whether it's a muscle, whether a part of a bone is marked off, or vasculature or a nervous structure. And a lot of the questions are ID. So identify this structure tagged by the white pin, identify the structure in the loop of the red string. And then some of them are what we call second order, which is going to be things like a muscle will be pinned and I can ask you what innervates this muscle. So you have to tell me what nerve is going to innervate that muscle. For your examinations, we have very little second order questions. It doesn't mean they can't happen, but we primarily focus on like ID, just like we do with our medical students. But like I said, if you come to the regional competition, it parallels very closely to what the medical students go through in their own examinations. So if you have any further questions about that, feel free to post in the chat. Otherwise, I'm going to hand it off to the med students and osteopathic second year students and see if there's any questions.
So I think somebody was asking about gap years earlier. I did 2 gap years actually. So I kept working. I got my EMT license. And so I worked through undergrad. I scribed in the ER, and then I also picked up a job on the ambulance on my gap year. And it was honestly like the best experience ever. Like um, I know like my parents were kind of like, oh, if you take a gap year, you'll never go back to school. But like I'm here now and like it was a blast. Like I really needed that break from school and I got a lot of like hands-on experience with actual like patients and it just like really solidified that like this is my passion and what I want to do. And then now that I've started school, like we have our like content like systems courses, but then we have like family medicine class and you practice doing like physical exam and taking history and like scenarios where you get to do like the doctor stuff. And being an EMT before was like super helpful with like learning all of that. I wasn't starting from like nothing. So that's what I did. And then my second year I actually moved to Colorado because I stayed in my home state for undergrad. And I was just kind of thinking I need to get out there and like see other parts of like the country and stuff. So I moved to Colorado and I kept working as an EMT, but I like teched in the ER instead of working on the ambulance. And that was really cool to see just kind of like all things in the ER from different perspectives. And it was also like really invaluable experience.
Ryan, you should jump in because you also are an EMT, correct?
Yes, and in this case, we're not talking epithelial mesenchymal transition. I was also a emergency medical technician. Yeah. So I also took a couple gap years after undergrad. I wasn't sure if I really wanted to commit, and it's a big commitment to even apply, for example. So I remember I took a gap year. I worked for some time um, as a lab technician. And then I went to grab my master's degree. And then I came back and sort of starting to work as a teacher while also working as an EMT. And then I sort of realized that like I liked teaching anatomy, but then I also liked treating patients. And then came this like kind of was like, well, why don't I just actually think about medicine again? And that's kind of when I thought about going back. It is something that takes a long time. The average age of matriculation in medical school is 26. Like people are no longer getting in out of fresh out of undergrad. So you don't need to rush your first 4 years. Take your time and figure it out. This is a 15, 20, well, now this is a lifelong commitment, not to mention like the 10 years of the, 4 years of schooling and however long of residency, right? So take your time with it. Sarah, should I pass on the bucket to you before we move on to the other questions?
Sure, I'm happy to pipe in. I also took a couple of gap years, so you can see that there's definitely a theme going on here. I spent my time, I also went to grad school, got my master's, and spent some time working. I think it's really, really nice to get a little bit of time off after college just to kind of figure out what you're doing, why you're doing it. I was motivated, so my master's is in anatomy, and I was motivated to do that because where I went to school, we didn't really have as many undergraduate level anatomy courses. So I wasn't really able to take that. You guys have an amazing opportunity through Anato-Bee to just get exposure here. So that was something I was really passionate about. I wanted to learn more about it before med school. And so I went that avenue to kind of learn more and like really developed a lot of my interests, kind of like Brian said, in teaching, in education, and anatomy overall. And so I would say it's definitely a healthy option. Don't just take a gap year to take a gap year. Like, kind of have not necessarily the most concrete plan, but know what you want to explore. I think it's a great time to learn new things, kind of explore, like I said, explore different things because once you start medical school, you are going to be very, very busy for a very, very long time. So anytime you have off in between school, take it and really, really use that as an opportunity to learn.
And
Yeah.
I think Sarah is being uh she so I worked with Sarah during her gap year,
Yes.
and she was the instructor for us at Jeff, and she taught in our anatomy labs.
Yeah.
So Sarah needs to give herself a little bit more credit, and I can personally say I watched Sarah in her gap year blossom into this wonderful anatomist.
Oh,
And yeah, and everybody loved her. And when she said she was applying to med school, we were all very sad because we didn't want her to leave as our instructor who helped us with the anatomy curriculum. And then she went in and became a med student. So I just had to put that out there because she's done a phenomenal job. I too took a gap year and I have a PhD in anatomy now, and I teach medical students. So keep that in mind. I will say, Sammy, you've had your hand up for a little bit, and then there is a question in the chat. So I want to say for the chat question, I think we've talked a lot about why you should go for gap year. The theme being it's important for you to understand what, take the time before you get into the long journey, because it is a long journey, whether you're going for a PhD and especially if you're going into medical school. But if you have any further questions, and as you can see, everybody here took gap years and didn't have an issue getting into medical school. But if you have any further questions, put them in the chat. I'm going to let Sammy. Oh, Dr.
Yeah,
Frank, did you have
I just
something?
wanted to add in, being on admissions, when we
Oh,
look at
yes.
applicants, we're looking at your resume, your entire portfolio. And we find those students that take a little bit more time, take gap years for personal experience, even for research. They have a much more robust resume, and especially I know a lot of them take time to do volunteering. All of that is very, very important. It's just not about your GPA and MCAT score. Everybody's got those, but what else have you done? And that's what sets you apart from everyone else. And I really encourage you, you're going to have to grow up, but don't grow up too quick, right?
Mm-hmm.
Get some experience, live life a little bit, get out there, experience what life has to offer, and then you can find if you really, really want to do it, and then make the commitment and apply. So I wouldn't worry about not getting accepted if you took a gap year or two. I actually kind of think, as a person on the other side, that it actually adds to your the quality of what you have to offer, and makes you much more I want you where I'm at, right? Makes you much more desirable. So think about that too.
Sammy, what was your question?
Well, so hey, again, it was just a few comments and questions too. And I'm going to make this really quick. I know I'm a yapper. First and foremost, I want to say thank you all so much. Thank you all so much. I'm still learning. I wish I was the world's smartest man, but I'm not. And honestly, attending these meetings, I know this is my last year, but attending these meetings and listening to you all talk and having a passion and yearning for medicine, I love it. You're all my favorite docs. That's actually what I call you all, my favorite docs. I call you all my favorite docs. You've taught me embryology, histology, and anatomical structures. I remember my first year, I think it was about 2 years ago, in the anatomy, and I made it to regionals, and it was crazy. I was like, oh my gosh. And now I'm our third year med president for MedCorps at UMC here in the Mississippi. And because of you all, I've had to lock in now. I've forgotten a lot of this stuff because it's like cram. But I got a lot of a few scholarships and a lot of acceptances to colleges. Thanks to you all, they had their most of the pre-med courses down here wanted you to take like a similar quiz like this or things like that. And I was like, I'm going to fail this. I did not fail. Thank God I didn't fail. But I just want to say thank you all so much. I do have a few questions and I'll wrap this up. Number one, I'm about to get my EMT license. So those of you that are EMTs, because I will say this, and my med proctors had to slam this into my head, both post-hospital and pre-hospital. It's very different. Oh my goodness. You can't give anybody nitrates. I remember one year we were talking about nitrates, if you remember that, Dr. Frank. But do you have any advice, so you won't get burnt out and stuff like that? Because I love medicine. I'm here for the long run, hopefully. So do y'all have any advice for me before I, go out and start a learning pathway and things like that?
Yeah, so for like burnout, especially EMT stuff, like you might see some things that are kind of like traumatic, I guess, but like if you want to do emergency medicine, that's kind of just how it goes. So I think just like make sure you have outlets and like people you can talk to if you're like, hey, like everyone's acting like this is really normal to like run a code and stuff, but I feel like weird about it. Like everyone else is feeling weird, they're just kind of not really showing it. So like definitely like go talk to somebody and be like, that was like kind of a lot, and just like be able to like compartmentalizing is good to like a degree, but like on your own time, like make sure you're good, and like so then you can show up and take care of other patients. Because if you're like thinking about some other call and then you go in and your head's not on straight, then you're gonna like make mistakes. So just make sure you have your outlets too, and like protect your time, and just make sure you take care of yourself too, I guess.
Okay.
Do you have, just because of the sake of time, did you have any other questions, Sammy? Maybe we can try to
All right.
answer, you can ask one and we can have one person answer kind of deal.
Okay. My last question. What are great study methods? I saw like a long list of, because I want to major in biology, pre-med, or biochemistry. Both are appealing, but do y'all have any great study methods for just all this? Of course, I'm going to be watching the videos like all the time, but any good study methods?
Yeah, I can take this one. So first off, the best thing to do is to figure out what kind of learner you are. So are you visual? Are you someone who's also like a visual spatial? Which in that case, diagrams, charts, flow charts, and tables are the best. Are you like someone who learns in groups? You know, maybe you like to talk it out with someone. Even if you're just at home, like if you can like lecture to your family pet or something. I've talked to my dog about anatomy countless times, right? Studying in groups, right? Highly effective if you can bounce things off.
Yeah.
But the best thing that I will always say is that this is a new language. So
Yeah.
repetition is king and queen. And seeing it multiple times from multiple angles, do a Google dive and just look at the different histologies. The more you see, the more it'll start to click, and that there really is a sort of art to how the human body comes together. But it takes repetition, and it also takes well, whatever works best for you. But for
Mhm.
me, I can say that I'm visual spatial. I love charts, tables, and concept maps. I am just my way in medical school. I do not really use flashcards. I just redraw my maps all the time. So constant redrawing, that's how I get my repetition.
Okay. Because it's great to know, patients hemodynamically unstable or whatnot, and clinical factors and diseases and illnesses, but you got to know the human body first. So, thank
Well,
you.
you're doing it and you're here and we can all learn together. But unfortunately, that's time, Sammy. We love your passion and your lovely questions. Please keep coming back and asking, and we'll hopefully have more time at the end to have these conversations. And I'll leave us with one thing Sammy said. I wish I was the most smart person. I do wish I knew everything. You made a comment about being the most smart person. I will tell you the smartest person or people I've ever known, and this is not just for Sammy, are the people that know they don't know everything. Because once you know everything, you stop looking and you stop being passionate. So it's okay to not know everything. Keep the passion alive, and we'll be here to enjoy the journey with you. So thank you all for coming for our second session in anatomy, and we look forward to seeing you in 2 weeks.
Bye.